for the last session. We want to begin. So you are requested to take your seats, please. And we will go to the next talk on anti-diabetic drugs and cardiovascular risk by none other than Dr. Y.S. Karim, the president of Kenya Association of Physicians. And Dr. Karim has already been introduced adequately. He's a consultant physician based in private practice in Mombasa, and I think all of us have seen him from the inception of the conference, so he needs no other further introduction. Welcome, Dr. Karim, for that talk. Thank you.
Thank you very much, Riaz, for those kind words. Good morning. I know we have reached the end of this marathon run of so many presentations and so many events. But I'm sure that you still have a little bit of stamina left to finish it. And after me, there is a closing ceremony. So let's stay in the auditorium and let's complete this job which we have started off. Now, my job was to talk about anti-diabetic drugs and cardiovascular risk. Firstly, do you remember when insulin was discovered? Can anybody give me a date? 1933? 23, yes. 23 is when insulin became available. It was actually discovered about 1922, and 1923 Nobel Prize for Medicine was awarded to Banting and MacLeod for that Nobel Prize for discovery of insulin. So you can see that it is less than 100 years ago that we in fact discovered insulin. And insulin is among the first anti-diabetic drugs to be discovered. In fact, prior to that, except for the last perhaps beginning 1900, diabetes had remained a very mysterious disease. Nobody knew what caused it. Very few people even knew about pancreas, and it was only some fortuitous experiments that led to the discovery that pancreas was somehow involved in the causation of diabetes, and it was again some experiments which were all accidental which led to the discovery that diabetes was caused not just by pancreas but by islets within the pancreas, which we call the islets of Langerhans. And Langerhans himself had described them without knowing them as to what they were almost a century earlier as a medical student. So there is some very interesting history which unfortunately we don't have very much time to go through. But in 1923, when insulin became available, it was thought that now there was complete cure for diabetes. And of course it took some time to dawn on clinicians as well as the general public that this was not a cure. This was merely a therapeutic armamentarium to manage diabetes. And it very quickly became apparent that even those who were treated with the insulin, while insulin saved lives from the very first physiological abnormalities of diabetes, such as polyuria, polydipsia, the cross-wasting, particularly for type 1 diabetics, it became a lifesaver. But it gradually began to dawn on people that insulin, in spite of insulin, diabetes complications continued. And these complications, which we today divide into microvascular and macrovascular, were apparently already there. The other problem was that there were two interesting things happening at the same time in management of diabetes. You must realize, of course, that management of diabetes must have been extremely difficult in those days, as there were no easily available apparatus to measure blood glucose. HbA1c was not yet even thought of or discovered. And so there were two things that were happening. One was that people were getting tired of insulin injections, and obviously they wanted to look for ways of finding something that would help diabetics control their blood sugar without injecting themselves. So the search was on for oral hypoglycemic agents. And fortuitously again, at that same time, there were antibiotics beginning to become available, not antibiotics as such, but antimicrobials. And these were sulfonamides. And somebody noticed that when they tried a new sulfonamide, these patients were getting very dizzy, very irritable. Some of them were lapsing into coma, some even had convulsions. And it took some very astute clinician to realize that these patients were actually having hypoglycemia. And we must understand that prior to insulin, hypoglycemia must have been an extremely, extremely rare occurrence, because only people with what we today now know to be beta cell adenomas or carcinomas which produced insulin, they were the only ones having hypoglycemia, because there were no hypoglycemic agents available in those days. And so from this discovery that these particular antibiotics or antimicrobials, which were sulfonamides, were causing patients' blood sugar to drop. And it led to the discovery of a new class of oral hypoglycemic agents, which we today call sulfonylureas. So these were derived from sulfonamide antibiotics. And already they were trying to develop these drugs. But what had happened is that at that time there were the clouds of Second World War looming up, and then the Second World War broke out, and most of this research was taking place in France. And so these oral hypoglycemic agents were no longer available at that time to UK or to North American markets. And even after the war, it ended up in East Germany, which was now under Soviet occupation, and some of this had to be smuggled in. Eventually, the first sulfonylurea hit the market by a company called Upjohn, and this hypoglycemic agent was tolbutamide. And tolbutamide really hit the markets with a big bang, because suddenly now you had an agent, oral agent that you could take maybe 500 milligrams 3 times a day, which was controlling the blood sugars of these patients. So there were some patients, and these were now the only second drug available for treating diabetes, because people had insulin and they had to give many injections, because still the long-acting insulins or additives which would make the insulin act longer had not yet been brought into practice, not yet discovered, and they had now oral hypoglycemic agents. And at that time people thought that they would have and produce for us a question which was already troubling at that time to many clinicians, which was that while there were microvascular complications, the major complication that was killing patients was actually cardiovascular disease. That about 65% of the deaths were in diabetics due to cardiovascular disease. And they were either due to coronary heart disease or to stroke or to heart failure. And the question became whether these drugs like insulin or even the new now oral hypoglycemic agent tolbutamide, would they decrease cardiovascular deaths? And in fact, the investigators at that time were so convinced that they would get an overwhelming answer that obviously if you are treating the blood sugar down, the cardiovascular mortality should go down as well. And so a very little known trial was arranged, which is called the UGDP trial, the University Group Diabetes Program, and it started recruiting patients in 1961. In fact, tolbutamide had become available about 1956, and this trial was already written in about 1959, and they started the trial in 1961. Now, it was the first randomized trial ever performed in diabetes. The other thing was that about the same time it had been found that when you used antihypertensive agents, you significantly reduced the incidence of stroke. So people expected similar findings, that once you reduce the blood sugar, you would significantly reduce cardiovascular disease. But it didn't turn out to be so, because it was intended to show whether oral hypoglycemic agents could reduce the risk of vascular disease in diabetes. And they had 4 arms of 200 patients each. One had a variable dose of insulin, another one had a fixed dose of insulin. There was an arm with tolbutamide and an arm with placebo. And of course, all these patients were on diet also. And later on, a fenformin arm was added on into the trial. So in fact, they ended up with 5 arms of about 200 patients, so they had just over 1,000 patients in that trial. But the study found an excess mortality in those who were treated with tolbutamide, 12.7% versus 4.9% in those who were on placebo, i.e. who were only on a diet. And when you compared the placebo and the insulin, they were again almost equivalent, which meant that insulin gave no advantage in terms of reducing cardiovascular mortality. And tolbutamide did not only give no advantage, it was harmful. And this trial was greeted with a big uproar. There were legal suits instituted against the trialists. Upjohn went on a rampage to discredit the trialists, because obviously it was going to affect the marketing of their product tolbutamide, which they were selling, I think, in the name of Orinase. And it generated a storm of controversy. And much of what happened is actually still affecting us today, because the idea at that time that FDA should have a say in the safety of medicines came with UGDP, and the idea that public should be warned of what kind of effects they have. Tolbutamide reduced the blood sugar, but it increased the cardiovascular risk. And again, it changed many things in the way that we practice medicine. So it was a landmark trial which we need to remember. And it brought about the coining of a word which we call glucocentricity, which is an irrational belief that lowering blood sugar using virtually any pharmacological means will produce a reliable reduction in adverse outcomes. And that, of course, was proved to be wrong, because obviously, if you just reduce the blood sugar, you did not reduce adverse outcomes. And we now realize that particularly for macrovascular diseases, we have lipid modification, glucose lowering, lifestyle intervention, BP lowering. All these have to be combined together for a patient to get any kind of cardiovascular risk reduction for these patients. And here again, we have got the ADA treatment recommendation that we do weight control, control the HbA1c, blood pressure, and lower your LDL cholesterol. And these reduce microvascular complications, but these reduce macrovascular complications. And again, UKPDS trial showed that you would get some reduction of even cardiovascular mortality in those patients who were treated with their HbA1c reduced to reasonable levels, and again blood sugar control was helpful. But again, it showed mostly that the reductions which came were in microvascular complications rather than in macrovascular complications. And then we got this idea of legacy effect, that you could have a good legacy effect if you are early strict glycemic control over a long time, and a bad legacy effect that if you have already had very poor control for a very long time and then you try to bring control, it does not improve very much the long-term complications. So it seems that for diabetes you need a very long period of very good diabetes control and control of multiple factors to effect any reduction in cardiovascular mortality. And that brings us to the question of that, is it worth getting your blood sugars down? And of course our first concern is that we should first do no harm with any medication. So now it became part of FDA and all other regulators' approval systems that we would have to demonstrate that a medicine is not doing harm, even if it is not doing any good. So if you have an anti-diabetic agent which does not alter cardiovascular risk, that's fine, as long as it gets the blood sugar down. But it should not increase the cardiovascular risk by itself as the drug added on to the risk that is already there as a diabetic. So you have a diabetic who already has a risk of cardiovascular disease, and now you add a drug which increases the risk, and that is unacceptable. And this is what has been happening. Here is just a timeline to show you that here was 1922, first exogenous insulin administered to a human, and first insulin, which was initially actually labeled as Iletin, became commercially available in the US. And subsequently we have had very many other additions, but you can see we are barely reaching 100 years from the time that insulin became available at 1923. So only in a few years' time we will have marked 100 years. And you will see that many of these medicines again have had to undergo rigorous testing to see that they are not harmful, even if they may be not helpful. And the same thing happened when we had the case of Avandia or rosiglitazone. The US Food and Drug Administration is aware of a potential safety issue related to Avandia, a drug approved to treat type 2 diabetes. Safety data from controlled clinical trials have shown that there is a potentially significant increase in the risk of heart attack and heart-related deaths in patients taking Avandia. So again, we had a drug. In fact, eventually tolbutamide was withdrawn from the market. Then the pharmaceutical companies came up with a notion that we are now introducing second generation sulfonylureas, which they claimed were more safer, and again not yet subjected to rigorous trials. But here was a drug which again showed that it was increasing cardiovascular risk. And so FDA came up with a requirement as part of the approval process for anti-diabetic medicines that a post-marketing trial generally will be necessary to definitively show that the upper bound of the two-sided 95% confidence interval for the estimated risk ratio is to be less than 1.3. This can be achieved by conducting a single trial that is adequately powered, or by combining the results from a pre-marketing safety trial with a similarly designed post-marketing safety trial. This clinical trial will be a required post-marketing safety trial, which means now that FDA was putting in that you have to show at least cardiovascular neutrality, if not benefit, for it to be registered. Because if it showed that it was actually harming the patient, in spite of bringing the sugar down, it was not to be registered by FDA. And here is the statistics that you had to show a non-inferiority boundary hazard ratio of 1.3, 1.8 in upper limit confidence intervals. So we went into an era of what we call cardiovascular outcome trials in diabetes. And what do we know so far? Now, we again need to look at how these trials are judged. These trials will be judged by what we call a MACE, which is cardiovascular death, which could be either myocardial infarction or stroke, or non-fatal myocardial infarction or non-fatal stroke. And you could add another component to it, which could be anything. It could be hospitalization for acute coronary syndrome, urgent revascularization procedures, or even heart failure. And this would constitute the MACE on which now you would judge whether a diabetic drug is safe to be given to the public. And here are some of the trials and ongoing cardiovascular outcome trials in type 2 diabetes. This is a little bit old, so very many of these, of course, have already reported, such as we have here 2018, 2019. Some are coming up, but most of these others have already reported. And these were some of the other trials for saxagliptin, elogliptin, sitagliptin, and these were all for DPP-4 inhibitors, and some for what we call now GLP-1 agonists, and we have one for the new type of medication, the SGLT2 inhibitors. So we will be looking at some of them in a little bit of detail. And again, this is continuing the same chart there. We have a GLP-1. We also looked at basal insulin, SGLT2 inhibitors, GLP-1 agonists, and this pioglitazone again. And what we find is that, for example, saxagliptin, while composite MACE was neutral, cardiovascular death was neutral, MI neutral, stroke neutral, any death neutral, but increased incidence of heart failure. And so one would have to be careful in using this drug for patients who already had fluid overload or who were in borderline heart failure, because this would tip them into heart failure. And we yesterday heard Dr. Wagela talking about heart failure, that heart failure itself is worse than most cancers in terms of prognosis. But you looked at other gliptins like elogliptin and sitagliptin, they did not improve in any way cardiovascular outcomes, but they were neutral. They did not do any harm. They did not have this red arrow there. But when you looked at now SGLT2 inhibitor, which is empagliflozin, you see that it reduced composite MACE, it reduced cardiovascular death, it was neutral for MI and for stroke, which is surprising because if it's neutral for all this, how did it improve these two? It decreased any death and it decreased the incidence of heart failure. And then we looked at, which is a GLP-1 agonist, and the only one that stands out is liraglutide, which again showed decrease in MACE, decrease in cardiovascular death, neutral for MI, reduced any death, but neutral for heart failure and other things. Whereas none of the others have really shown very much of a promise. So, just as an example, we will look at two trials on SGLT2 inhibitors. One is on empagliflozin, which actually was approved by FDA in August 2014. And although canagliflozin was approved earlier than empagliflozin by a few months, it reported its findings at a little later date. And So we'll look at empagliflozin cardiovascular outcomes and mortality in type 2 diabetes. Now they randomized 7,020 type 2 diabetic patients who already had cardiovascular disease, mean age of 63 years, A1C of about 8%, BMI, so they were all slightly overweight, and they were either randomized to 3 arms, 10 milligrams or 25 milligrams of empagliflozin with placebo. And now the design of the trial was such that everything else had to be equal in all the arms. That means you could control the diabetes in the placebo arm with any other medication, including insulin, to control the blood sugars. So you were really looking to see if everything else was equal, whether adding empagliflozin made any difference. Now, the primary outcome that they were looking for was death from cardiovascular causes, non-fatal MI and non-fatal CVA, which is what we talked about, MACE. And here you can see that surprisingly, although everything else was equal, there was a slight reduction in A1C for the active treated patients. So 29% and placebo and 23% of the active drugs, they discontinued the treatment prematurely, which again would somehow affect our end results. But cardiovascular death was reduced by 38% in the empagliflozin arm compared with the placebo, and hospitalization was reduced by 35%. And here are all the other things showing the primary outcome of MACE, again reduced, death from cardiovascular causes reduced, hospitalization for heart failure reduced, death from any cause was reduced in the empagliflozin arm. Again, we now look at the integrated results of the CANVAS study, which looked at canagliflozin, and their design was a little bit different because they first had to meet the FDA standards, so they started with a smaller number, and then they added on an extra number to make the total of 10,000 patients to evaluate the cardiovascular safety. And they again took all those patients who had type 2 diabetes over the age of 14 years, at high cardiovascular risk, they were hypertensive, overweight with multiple comorbidities, and 2/3 with prior cardiovascular disease, and 1/3 on primary prevention. And what you found is that these were diabetic patients, and diabetes with cardiovascular risk factors that form 40% of the study population, and diabetes with established coronary artery disease formed 60% of the study population. Now effects, again, surprisingly, the HbA1c dropped, although as we saw again in UKPDS, that years after randomization, the HbA1c tends to always get very close. So those early advantages seem to be lost. And the biomarkers again showed the similar effect. The CANVAS program was, even so there was a glycemic advantage and a slight blood pressure drop. Urinary albumin was also reduced. Body weight was reduced. And primary outcome, there was a 14% reduction, and lower, but again, looking at the side effects, it was interesting that these patients had increased risk of lower extremity amputations, slight increased risk of those who are on canagliflozin. So if you looked at the benefits and risks for these patients, by MACE, you had 23 fewer patients per 1,000 patients over a 5-year period, but amputations were were slightly risked. Most of them were above, very few above the ankle. Most of them were toes and so on, which required amputation. So the CANVAS program met its primary objective of demonstrating cardiovascular safety and also showed efficacy of canagliflozin for the prevention of cardiovascular events. It was associated with an increased risk of amputation, which should be taken into consideration when prescribing this agent. This data suggests net overall benefit of canagliflozin for most patients with type 2 diabetes and high cardiovascular risk. And if you combine these two together, then you can see that both of these have very similar outcomes. These are both SGLT2 inhibitors. So it would appear that it is not anything fantastic about empagliflozin itself or canagliflozin itself. It is a class effect that all SGLT2 inhibitors seem to confer a protection in cardiovascular outcomes for diabetics. And again, this has been shown in a real-life situation from registries of outcomes. Now, what is the explanation for the reduction in the cardiovascular death? No difference in rates of myocardial infarction or stroke, as I pointed out to you, and yet when you look at it overall, the deaths are reduced. Only 10% of these patients had heart failure at baseline, and some would suggest that it is the diuretic effect of SGLT2 inhibitors which is causing this, but we know from other trials that diuretics by themselves or even digoxin and others have had no mortality benefit. So how did SGLT2 inhibitors improve mortality? Was it related to this modest BP reduction? Was it related to the modest weight loss of about 2 kg? So this is again unlikely that you would get such fantastic differences in cardiovascular mortality. So it looks more like that we still have not identified the mechanism of why SGLT2 inhibitors as anti-diabetic agents are proving useful. And before I stop, I would just say that there are already questions about whether we can use SGLT2 inhibitors for patients who are not diabetics to give them the cardiovascular benefit. For instance, if you have a patient with cardiovascular disease with heart failure who is not a diabetic, would he benefit from taking an SGLT2 inhibitor? And these trials are underway and we still wait for them to report. Thank you very much.
The only caution I want to make is that, yes, it is true, you are putting people on medications and you notice there is a reduction on this other side, but there are so many other confounding factors that could easily be the reason rather than these medications. And I think that is one thing. I mean, just simple weight reduction, reducing the BMI and reducing the cardiovascular risk, is not taken into considerations and so on. So I think these are the kind of things that we need to take into consideration as well.
Yes, I think the trialists have balanced the two sides or the two arms of the trial in terms of all the risks prior to starting the trial. So all these other confounding risks have been taken into consideration, and yet somehow, again, even in these were the level on the population of the trial who were all at high risk of cardiovascular disease. But actually the registries in countries where such registries are kept, like Scandinavian countries, Germany and so on, show that we didn't have time to show all these slides, but they show that the same benefits are given to even patients with very low risk of cardiovascular disease, such that even patients who are first-time diabetics at the age of 40 and so on, patients put on these drugs even in fairly short period of time, they're already beginning to show advantage in terms of cardiovascular risk.
So mine is a comment, so hopefully the two questions will remain. So about the Canvas study, what we notice is that the authors do not declare the conflict of interest in the actual paper, but they do declare in the supplementary document that they were funded by the company that produces the canagliflozin.
Thank you very much. That was a very good presentation. But one wonders why there is an increase in the amputation risk. Are there any other confounding factors that were not analyzed in the studies?
Thank you for the excellent presentation. I'm just wondering, because from the presentation I wasn't able to calculate number needed to treat or number needed to harm. Yes, then for us clinicians, that would give us an inkling on the impact of these findings. Thank you.
Thank you. I think first we come to the idea of what could be the mechanisms for the amputations. Frankly, I don't think anybody knows at this stage, and these were only noticed in this Canvas trial. They had not been noticed in empagliflozin's trial. And again, all the other follow-ups of registries have not shown this particular risk of amputation. So we don't know why this particular trial had shown this increased risk of amputation of toes. Luckily, the proximal amputations were very, very few in number. On the question of numbers needed to treat and the numbers needed to harm, I showed one slide with some numbers. Obviously, I'm not discussing these trials in very great detail because that would require a lot of time, which I don't have. But by and large, some of the figures were given, and it seems that the numbers needed to benefit are very, very good numbers. You need to treat only very few patients to get the benefit. Whereas if you looked at the numbers needed to harm, these are much larger numbers, so your chances of doing any harm are pretty small. But again, you need to look at the whole trial in very great detail, which we have not done. We were just giving a very brief overall sort of glimpse, a bird's eye view of trials, of why these trials have come about and why it is necessary for us to now examine any anti-diabetic agent, or for that matter any other pharmacological agent which we introduce, and it has to demonstrate not only that it is reducing, for example, blood sugar or a blood pressure reading, but does it actually affect the outcomes of these patients. So that was the whole idea of this morning's presentation. But thank you for your question.
Thank you, Dr. Y.S. Karim.